just joined, as I said, this is the launch for our Pan-London repatriation guideline, which we have updated in the last year. I can hear a lot of voices on this. Everyone could turn their mics off. That would be really helpful. Thank you. And feel free to turn cameras off while we're just presenting through our initial slides. Slides will take about half an hour, and then lots of time at the end for questions to members of the Task and Finish group. So through the next half an hour or so, I'm going to run through some slides, which essentially will just quickly go through the background definition of repatriation and how we've come to having this new updated guidance. Then we'll spend a little bit of more time focusing in detail on the new repatriation process overview flowchart, which is the most updated element of this guideline. We then have new elements that we've put in. There's lots of information to help support parental communication and to help guide parents through the process of getting them ready for the difficult process, which is often the repatriation that takes place. And then we will talk about escalation processes and what to do when repatriations aren't happening in a timely way. Think a bit about governance, and then some other key additions and updates. So just going to the background of how we got to this point. So the original guideline for the original Pan-London repatriation guidance, we put together in 2020, 2021 with a Task and Finish group, because it's such an important part of what we do as neonatal services. With over 1,500 neonatal repatriations occurring annually across the London network alone, we wanted to put a guideline in place to try and improve efficiency, safety, and the overall family experience. This partly came off the back of some quite serious incidents that occurred around repatriation. So we want to try and have systems in place that make sure that babies are safe, stable, and ready for transfer at the point that decisions are made to move them. And we also want to have systems in place to try and promote the escalation through the escalation of care that's required when there's delays to repatriation. And we'll come on to that in more detail. So the focus of our Task and Finish group is to look at essentially babies that fall into 4 key groups. If we move on to the next slide, Nigel. So the definition of repatriation, which I think often causes some confusion, this is not babies that need escalation of care. This is for babies who, this guideline is to focus on these 4 groups of babies. Babies who are mostly no longer needing intensive or specialist care provided in the current place where they're residing, but require continuing care and can often receive that care closer to home. The second and third groups are babies who are admitted to a unit outside of London, but due to capacity within their own London network and need to be transferred back in, or to babies who are born unexpectedly within the London ODN whose family reside outside and need to be transferred back out. And then in more rare circumstances, we need to move babies and families really purely to support with capacity in tertiary centres, potentially moving them to a local neonatal unit, which is not necessarily their nearest one, but we need to be able to free up the capacity within the tertiary centre. So these are the 4 key groups that we focused on with our guidance. The process that we went through to get to this new version of our guideline was to have a new Task and Finish group commissioned by the London Neonatal ODN with representatives from a wide representation across the MDT, including the service users voice group, to ensure that there was collaboration and co-production with everybody who's involved in repatriation. We had monthly meetings over the last year with multiple iterations of the guideline. Also various scoping exercises to look at specific issues, multiple discussions, sharing of the guidance before every meeting with opportunity to change things, correct things. And then ultimately we finally came up with a final draft of our guidance, which was submitted to the London Neonatal Group in July for ratification, which is the guideline that will have been shared with you and the one that we're launching today. Just in terms of a bit more background, between the initial guideline that we developed in 2020 and this revision, there was a launch of the BAPM repatriation guidance. And so we've incorporated some additional elements because of that guideline. And also we reference that guideline quite a lot. We don't need to reinvent the wheel. A lot of the resources within that are excellent. So we utilise that as well within our local pan-London guidance. So then if we just come on to our flowchart. So this is a updated version of the flowchart that was in the original guideline. There are a few more key elements. We've added some colour. It's a big flowchart, and there's lots in there, and there's lots going on. But it's really just to help provide a summary of every stage that's involved within repatriation. And as you can see from this diagram, repatriation is so much more than a single ambulance trip from one neonatal unit to another. There are multiple stages involved, and you'll see from the big arrow across the bottom, probably by far the most important element to getting repatriation right for all involved is communication. And that doesn't just mean communication, verbal communication. It also means our documentation processes and making sure that we're collaborating with all members of the multidisciplinary team and with families at every step of the way, whenever possible to do so. So if we start over the far left-hand side of this flowchart, we are looking at a baby who is not in their local unit, and that's essentially where we're going to start with every repatriation process. As soon as a baby is not in their local unit, whether they've been born there or whether they've been moved there as part of an escalation of care, or whether it was an in utero transfer, if their local unit is going to be somewhere different, then it's really helpful to let the local unit know as soon as possible that that baby exists. So within stage 1 of this document, we would want the local units to be made aware early and families to be made aware early. In an ideal world, families will be aware that repatriation is likely to happen at some point, even potentially before they deliver, and it can be involved in some of the antenatal counselling as well. This document is colour-coded to try and link together the kind of themes of the important elements of repatriation, whether that's thinking about safety, decision-making, the processes themselves, or the communication. So as you gradually move through, it's quite possible that for stage 1, a baby will be in most commonly a tertiary centre for a significant amount of time whilst they're going through their acute newborn phase and stabilisation and that early intensive care treatment. At some point, the referring or the tertiary team will feel that the baby is clinically suitable and safe to transfer. And as per the red box, the guidelines within this document are exactly the same as they were from the guidance that pre-existed. We haven't changed this. So not receiving invasive ventilation for at least 24 hours, low flow nasal cannula oxygen or room air. If they're on high flow or nasal CPAP, then ideally less than 40% for 48 hours. And clinically stable for at least 24 hours with no increase in their oxygen, no significant brady's, apneas or desaturations. We appreciate that this is, some of these things might be slightly difficult to achieve, but in order that a baby is going to be safe for their repatriation journey and then easy to assess and review on arrival, having these key elements in place is really, really important. We've specified that the weight for repatriation should be around a kilo, around 1,000 grams. However, it's reasonable that babies between 800 and 1,000 grams can be discussed if they're particularly clinically suitable or clinically stable. And so the 1,000 grams doesn't have to be an absolute cutoff, but it's well recognised, particularly by NTS, that babies are more robust and seem to cope much better with the transfer journey and that period of upheaval if they're closer to the 1,000 gram mark. Everything that we have in this guideline is a guideline. Things don't have to be absolutely black and white, but with good collaboration and communication and conversations, there can be some individualizing of how things are done. But we just want to make sure that things are as safe as they possibly can be. So we would advocate for ongoing conversations and updates to take place throughout the time that baby is receiving intensive care and gradually getting to a point that looks like they're heading towards repatriation. It's very helpful to update local units, to potentially talk to the parents about the unit that they might be going to, maybe point them in the direction of resources that they can use to become familiar with the unit that they'll be going to. And at every step of the way, keeping records of the kind of communication that has taken place, especially if there have been particular problems with that communication, whether that's with the family or between clinicians across different units. We still have the repatriation communication record. It's been updated and there's a little bit more detail from the original guideline, essentially to try and always use that within a receiving centre to record all conversations and communication about a particular baby, to try and make it as smooth and straightforward as possible for the referring centre when they're calling back to discuss or update on a particular baby. It's very frustrating for the referring centres if the receiving centre have no recollection, no knowledge. In the past, not so many years ago, scraps of paper were used to document these conversations and they weren't really kept and recorded. That shouldn't be happening now. The repatriation communication record is a good way of logging all those calls, and it can then be used and feed into the baby's record once they've arrived on your receiving neonatal unit. And often you can get little snippets of information within those conversations that you won't necessarily get in the discharge summary. So the senior nurses are key throughout this process in terms of linking in with receiving hospitals, working out using our repatriation threshold charts, which neonatal unit is going to be most suitable for this baby to be going back to, then linking in with senior nurses in that centre to start the conversations. And when the time comes and as we move towards stage 3 and 4, keeping a careful link in with the receiving centre to be sure when cots become available and trying to get those cots secured and ready pending the repatriation journey. Within stage 3, you'll see we've specifically divided up medical handover, nursing handover, and AHPPP handover. This is new, that we're sort of trying to encourage this in more detail. We had feedback from AHPPPs that often they weren't included in the repatriation process at all. They'd suddenly find that babies had maybe left their unit, and of course any conversation that they can have with their opposite number in a receiving hospital are going to be very helpful in terms of ongoing care for that baby, whether that's the speech and language therapist handing over detailed work that they've already done with the baby and the family, physiotherapists, pharmacists, whatever. There's huge amounts of knowledge there that can be handed over to try and improve safety and improve the overall care for the baby and the family. We then get to the point where we're now looking like babies close to being ready for transfer. And this is where either NTS come in, or potentially a neonatal unit might decide to actually run their own transfer. If they want to do that, then we would really advocate the use of a safety net tool to check that everything is in place and everything is safe for that baby to then get into an ambulance and move across London. So we include a link to our to a safety net tool to use in that situation, and NTS have their own safety net tool as well. So as we're coming just to the point that the baby is pre-transfer, this is the point where often information can get missed out and communication can sometimes fall apart. So we did a scoping exercise and found out that none of the tertiary centres that we spoke to had a specific checklist for ensuring that documentation is handed over. And by that, I mean growth charts, x-rays, final swab results. Is there a record that EBM has left with the baby? All these things, any one of which can sometimes get omitted, and particularly the clinical details of exactly what has happened to that baby in the few days before they leave the referring centre. Often discharge summaries are written days or even weeks in advance, and there'll just be a very brief update. As a receiving centre, it's extremely helpful to know if there's been changes in ventilation settings in the previous 48 to 72 hours before the transfer, or if there have been changes in medication or changes in the feeds or feed frequency. And there often are changes in that window. So really helpful to make sure that that information is included in discharge summaries, in conversations that happen in terms of that final medical handover. And the checklist is designed to try and help facilitate just dotting the I's and crossing the T's at this point. So we've included that within the guideline. It's really just a basic guide of a checklist, and I'm sure different units could put together their own version of that. But it certainly seems sensible in terms of trying to prevent these omissions that regularly occur. So once a baby is considered ready, clinically ready for transfer, then ideally on the day where transfer is planned, that final examination of the baby, checking that they're safe to leave the building on that day, should occur as early as possible, ideally before 7:30 in the morning, so that particularly if NTS are being used for the transfer, NTS start at 7:30. So if they can already be told at that point, yes, this baby's been examined, they're clinically safe and ready for transfer, and the receiving unit can be updated. Ideally, they would also know, hopefully from the discussions that have taken place in the hours or the day before, that their cot is definitely ready. And the repatriation journeys can begin early in the day whenever possible, which will help facilitate as many journeys being able to take place within each 24-hour window. And key to all these, at every step of the way, is that parental involvement, involving with families, making sure they're fully updated, make sure that this difficult and stressful time is contained and made as stress-free as possible. So then we come to the transfer itself, which will, by the majority of cases, will be led by the neonatal transport service, and the period immediately following transfer. In that window, immediately after transfer, within the receiving unit, very helpful to families to meet a senior clinician as soon as possible after they've arrived, just to give them, to make them feel welcome and to give them an overview of what's likely to happen now that they've arrived in a different hospital. And within that sort of 24-hour window after a baby arrives in a new hospital, is also very helpful if there have been any problems with the information that's been handed over. We advocate using local governance nurses, discharge coordinators, clinical leads to fill out instant forms or DATICs to feed back when omissions have occurred, so that we can improve the quality of how transfers are happening. It is very common that small things are missed out. We're not talking about big serious incidents, and hopefully they will be vanishingly rare. And if they happen, then I think people get involved quite quickly, and there's cross trust discussions, and everything is handled. It becomes a very big deal. But I'm really talking about those small things that actually can contribute in a very big way to the safety of a patient. If a patient arrives and you don't really know what changes have happened in their ventilation in the preceding few days, or they just seem to be a bit more unstable, it could easily be because of the journey that they've just undertaken, but it might also be because they're colonized with a bacteria that you don't know about because you haven't received the most recent swabs, and now they've become infected. As much information as possible handed to the receiving team will only help to improve the care that the receiving team can give. And we really want to try and encourage that conversation between the receiving governance nurses or clinical leads and the referring governance team to try and tighten up when there are problems, and potentially keeping a record of what's been happening and looking for common themes. This can then be fed back to the clinical oversight groups, and we envisage, with the use of more governance and with a handover checklist, that hopefully these omissions will become more and more infrequent. So I think that's essentially that flow chart. If we move on to the next slide. So Ellie Atkins, our psychologist who's been working with the Task and Finish group, has done a really good job here of giving some nice steps and guidance around parental communication throughout the process of gearing up a family for the inevitability of a repatriation journey and moving to a different neonatal unit. So she's given lots of guidance here about the kind of conversations to have, resources that you might want to use, and things to think about at every step of the way, from the point that the baby arrives on the unit right through to the time that that repatriation process takes place, and then they arrive on a new unit. And I'm sure that I think we have Ellie within the team to answer questions on this, but this also ties in with the BAPM resources on parental communication, which we've also included links within our guidance, and they're also very useful. Okay, moving on to the next slide. So one of the biggest issues that we have in London is the capacity to move babies into tertiary centres, and so it's really important that the network can flow and babies can move around. There are enough cots across London, but often the babies there are points at which babies aren't moving when they should be, and so cots are being blocked in the wrong places, and there becomes a bit of a bottleneck to move babies back to their local units. And for this to happen well, everything needs to be thought about that was in that flow chart, and really good communication needs to happen. If things are slowing down and it looks like a repatriation isn't going to occur, then you need to go back to the basics of what's taken place and what's happened and check documentation. The consultant to consultant discussion in terms of accepting a baby for medical transfer, to be medically safe for transfer, is really, really vital, really important. So keep local records of those conversations that take place in the referring centre so that it's easy to link in with the receiving centre. A repatriation transfer should occur as soon as possible after an infant has been medically accepted for transfer, which is a two-way thing. It needs both the referring hospital that have the baby under their watchful eye that they've probably looked after for many weeks, particularly if it's a complex baby. They've provided amazing care for weeks and weeks and weeks. And now this is the point where things can get a bit risky and they need to be moved across London to a different place. So it's worth investing time in that handover process, making sure that both sides, the referring and receiving centre, have understood everything that's going on with the baby, and both sides have agreed the baby's medically accepted for transfer. Once that's happened, ideally, the transfer would happen within 24, 48 hours. If it hasn't, then we would recommend that an incident form should be completed by the referring unit as a record that there's been a delay in the transfer. Then there should be re-engagement with the on-site clinical team at the referring centre. So re-engage with the lead consultants, the attending consultants, discuss again or if discussions hasn't actually happened at consultant level, this would be a really important time to get consultants involved. If the delay is more than 72 hours, to assist with the logistics and to try and to provide some sort of support to the receiving team, then it's worth involving senior clinical leads on the receiving site, and to involve matrons on the receiving site to consider, is there anything that can be done to help facilitate that transfer? Is it because there isn't enough staff, a cot's limited for various reasons, other infection control issues potentially that are being maybe taken out of context? The idea about this escalation process is not to be penalising anybody, but more to be working collaboratively to try and look at problem solving to actually then enable babies to be moved to their local centres to then hopefully free up the space in the referring centre. So we would definitely advocate to work through this escalation process, try and remain as collaborative as possible, and keep really clear records at every step of the way, that will always help in terms of if you're in the referring centre and you're ringing a receiving hospital, to be able to say, I've already spoken to Dr. whoever. Hopefully they will have clear records within their repatriation communication record, but just those clear communications will, as I say, will just help things work efficiently and help us all. I don't think everyone ultimately is going to want the best for the family and the baby, and delays to repatriation can really cause an escalation in the distress to the family, because there's a lot of uncertainty once they're stuck in one place when they think they should be in another. Okay, so just moving on to really just other bits that we've included and updated within this guideline. So I've already mentioned medical review on the day of transfer happening as early as possible in the day. We've mentioned daily sector nursing huddles within the guideline. These have been introduced in the last year or so across London, and including conversations around babies who are waiting for repatriations, especially if there's potential delayed repatriations for more than 48 hours, within these daily huddles could help to facilitate movement. So that's one area that we would want to advocate for and to change slightly in terms of what currently happens. We've talked about the escalation process. We've talked about AHPPs already. In terms of incident reporting and governance, as we talked about at the end of that flow chart, using your governance leads on site to just feedback and improve the quality of what's going on with the data exchange during the repatriation process. And then there is now a new and probably what will seem quite a big change across London, in that NTS are able to provide 2 teams overnight. So there will now be the opportunity for out of hours and overnight repatriation transfers across London. This will be met with some concern and anxiety, particularly in receiving teams, but also with a lot of joy, because this is going to hugely increase the amount of transfers that can take place, especially with emergency transfers, which is going to really help with patient safety. Within the guideline, we've included some quite basic guidance around babies that are suitable for out of hours and overnight repatriations. Obviously, out of hours and overnight teams are, particularly in receiving centres as opposed to the tertiary centres, are likely to be smaller teams. There's unlikely to be consultant presence, and so we've looked at what the Panda team have already been doing with this in the Cambridge area and used their experience to help feed into this. And essentially, they would advocate trying to avoid any complex babies out of hours, so where possible, and avoid moving the most preterm and the smallest babies. So trying to keep essentially more to the 32-week plus group of babies. It lends itself to moving term babies, particularly if they've had a short transfer, maybe just to exclude surgical abdomen or something like that. In that case, it's quite possible that the mum still, or the parents might still not have even left the initial neonatal unit. So in that situation, parents are going to absolutely welcome an out of hours transfer. But there's no doubt that introducing out of hours and overnight repatriations could increase anxieties for families and parents. And this just wouldn't be suitable for those babies who've had a very long and complex stay. And the other advice from Panda was to try and initiate those repatriation transfers within the first half of the night, if possible. The repatriation out of hours being considered really kind of after 6:30 at night. And of course, receiving centres are going to have to be able to support and agree before those repatriations can actually happen. But everyone's hoping that we'll be able to work together with this to help facilitate a lot more repatriations happening within a 24-hour window. And we've already talked about the handover checklist. So finally, in summary, this new this new guidance, as really with the last slide, Nigel, I think, with the as with our original guidance, clinical safety is absolutely paramount and should remain top of everyone's agenda who's managing repatriation. Trying to think about moving babies and supporting families in an efficient and timely way, but with a trauma-informed and family-integrated care framework, and trying to help improve the experience of families throughout every step of this process. Communication, I've said multiple times, it's all about timely, frequent, multidisciplinary, accurate communication at every step of the way, and using our repatriation communication record within receiving units. Multidisciplinary communication as again at every step of the way. Utilising escalation processes, as we've explained, when there's a delay to repatriation. Using the governance leads and governance nurses to assist with processes to try and improve the quality of the repatriation process. And then finally, accurate data collection by utilising the Badgernet discharge form. If the referring centres are actually using this and filling this out, then it means we can actually use Badgernet to help audit repatriation. At the moment, it's really hard to collect any real accurate data around repatriation. So definitely, this is a plea that people use that form. And then finally, as a result of this guidance, well, actually, it's not as a result. Having written the guidance, the service users group have come up with with an awareness of what is in this guidance, a really, really helpful repatriation parent information leaflet, which I think parents are going to find invaluable as a support for repatriation. And so look out for this. It's going to be coming soon to all units. So thank you. That's the